By the end of this presentation, I hope you'll be able to describe the proper administration technique for eye drops, ointments, and gels, including nasolacriminal occlusion and tips for administration to children. I also hope that you will be able to understand the mechanism of action, common side effects, dosing strategy, and patient education points for the agents in the following conditions: conjunctivitis, dry red eyes, and glaucoma. The eye is a hollow sphere composed of 3 layers of tissue. The fibrinous tunic includes the sclera, which is the white of our eyes, and the clear cornea, which covers the anterior tip of the eye to allow light to pass through. The vascular tunic includes the vascularized connective tissue and the iris, which is the colored part of the eye that's smooth muscle, and is responsible for opening and closing the pupil in response to light. And lastly is the neural tunic, which is also known as the retina, and it contains the nervous tissue responsible for photoreception. There are also 2 cavities located within the eye: the anterior cavity, which has the aqueous humor, and posterior cavity, which has the vitreous humor. In order for an eye drop to be safe and effective in the eye, there are several different properties that this eye drop must have. It must be sterile and free of foreign particles. It has to contain a suitable preservative, but it needs to be free from irritating effect. It also needs to be isotonic with the lacriminal secretion and chemically stable. Lastly, a drop volume can only equal around 50 microliters. The normal volume of a tear is around 7 microliters, and the whole eye can hold up to 30 microliters of liquid without spillage. This is important to keep in mind when we're educating our patients on proper administration technique.
In order to achieve the previous properties of an eye drop, there are some common ingredients. First and foremost, there's always a drug or an active ingredient within the product. There's also several different types of preservatives that can be used. There's surfactants, which can help to improve solution clarity, pH buffers and adjusters, tonicity agents, and viscosity agents. I'd like you to focus on recognizing the agents in blue as preservatives. Preservatives can be irritating for some patients, and often a patient will not be able to tolerate one preservative but can tolerate another. Therefore, simply switching from one product to another within the same drug class may help out with side effects and keep efficacy due to the differences in preservatives. There are many ophthalmic dosage forms on market today. There are liquids, semi-solids, solids, and intraocular forms. The preparations we'll be focusing on today are in the liquids and semi-solids categories. Another way that ophthalmic dosage forms are categorized are either by solution, suspension, or emulsion. You can see the different advantages and disadvantages of each of these types. It is important to educate our patients on proper eye drop administration, not only for efficacy but also to help reduce complications such as infection. Many patients will want to touch the tip of the bottle to their eye directly. This increases their risk of infection and therefore should be educated against doing that. You can see all 10 steps of proper eye drop administration listed here. It's important to note that when a patient is administering multiple medications or multiple drops, they'll need to wait at least 5 to 10 minutes between the medications. This is because the capacity of the eye is really only for about one drop at a time. For contact lens wearers, they need to wait at least 15 minutes before inserting contacts after the administration of an eye drop. Another important education point to make during the proper administration of eye drops is nasolacriminal occlusion. Our lacrimal glands secrete tears to wash away foreign bodies, but also to moisten the cornea and prevent dry eye. Nasolacriminal drainage allows for a pathway for systemic absorption of ophthalmic agents. Therefore, nasolacriminal occlusion and eyelid closures decreases systemic absorption by about 60% and also increases the bioavailability of the drug, leading to better efficacy and fewer side effects. In order to do this, you just instruct the patient to close their eyelid and apply pressure to their nasolacriminal duct for at least 2 minutes, which is on the inner corner of the eye near the nose. For the parents administering these eye drops to their children, there are a couple tips and tricks in order for proper administration. First is to have the child lay down on their back with their head on a pillow or a plush toy for comfort. Secondly, if the child resists the eye being touched due to pain or discomfort, they can have the child lay down and close their eyes. The parent can then place the eye drop on the corner of the closed eye near the bridge of the nose, and then have the child open their eyes. This allows the drop to fall in naturally from the corner of the eye into the eye itself. There are a couple of differences when a patient is administering an eye ointment or gel versus an eye drop. First, the patient will need to pull down the lower lid to form a pocket, and then instead of placing a drop into their eye, they will squeeze a ribbon into the pocket and then blink gently and close their eyes for 1 to 2 minutes.
The first disease state we'll talk about today is conjunctivitis. Conjunctivitis is inflammation of a thin, transparent layer of tissue that lines the inner surface of the eyelid and the sclera. It's a very common disease state with around 4 million cases per year. Common symptoms include pink or red sclera, itching and burning, ocular discharge with complaints that eyelids are stuck together in the morning, feeling of a foreign body in the eye or fullness around the eye. Pain, increased light sensitivity, and blurred vision are rare with uncomplicated conjunctivitis. If a patient is complaining of these symptoms, conjunctivitis is unlikely, and the patient should be referred to an eye specialist. There are 3 main causes of conjunctivitis: allergic, infectious, and chemical. Today we will only focus on the treatment for allergic and infectious.
There are some major differences in symptomatology between the causes of conjunctivitis, and they are listed in bold. As you can see, bacterial conjunctivitis is usually unilateral with purulent discharge, whereas allergic conjunctivitis is bilateral with watery discharge and lots of itching. Viral conjunctivitis is more common in adults, and adenovirus is particularly contagious. 15% of cases of conjunctivitis are bacterial, whereas 50 to 75% of pediatric cases are bacterial. Children 3 months to 8 years are more likely to have infections caused by staph, strep, or H-flu. And gonorrhea or chlamydia are likely in sexually active teens and adults. Bacterial and viral conjunctivitis can be highly contagious, and patients may be contagious for up to 48 hours before symptoms are present. Bacterial conjunctivitis is usually self-limiting and will resolve within 1 to 2 weeks, but antibiotics shorten the length of infection and reduce the person-to-person spread. In fact, most schools will require treatment before a child can return to class. The patient will need to stay home for at least 24 hours after discharge from the eye is seen, or 24 hours after starting antibiotics. Empiric antibiotic treatment is broad spectrum and focused on staph coverage. Tobramycin and gentamicin are reserved for more serious infections, and fluoroquinolones are typically last line due to their poor strep coverage and high cost. Fluoroquinolones cannot be used in children less than 1 year old. If there are no improvement on one of these first-line or second-line agents, referral to an eye care specialist may be necessary. In the United States, there are 4 classes of ophthalmic antibiotics currently available. However, no clinical differences in the efficacy of these antibiotics has been discovered. As a quick review, bacteriostatic means that the antibiotic prevents the bacteria from further growth, but relies on the body's natural immune response to clear the infection, whereas bactericidal means that the antibiotic will actively kill the bacteria. There are increasing resistance to older generation antibiotics, and therefore there has been a shift towards fluoroquinolone use. If a fluoroquinolone is prescribed as a second-line agent, symptoms should improve within 3 days of initiation. If there is no symptom improvement in that time, then referral to a specialist is warranted. Viral conjunctivitis is self-limiting and typically resolves within 5 to 14 days. Antibiotics should be avoided and do not improve patient outcomes. Treatment instead is focused on the patient's symptoms. Lubricants can be used to reduce the gritty feeling or the sensation of a foreign body in the eye. Symptoms similar to an allergic reaction may occur due to the preservative in the product. There will be a slide later that shows each product with the different preservatives. Cool compresses may be used to negate any pain or warmth. Since viral and bacterial conjunctivitis are highly contagious, it's important to educate our patients on transmission reduction. They can reduce the transmission of this infection by washing their hands often and avoiding touching the eye, using separate hand towels, avoiding contact lens use, and discarding any eye makeup that was used prior to the infection. It's important that they continue these techniques for even days after initiation of treatment due to the fact that bacterial is still active for 48 hours after treatment initiation, and the virus is still contagious for up to 14 days after initiation of treatment. Allergic conjunctivitis is inflammation in response to an allergen, causing mast cell degranulation and inflammatory mediator release, including histamine. First-line treatment includes over-the-counter antihistamine and vasoconstrictor agents. Vasoconstrictors are inexpensive, over-the-counter, and therefore first-line. However, these agents should only be used in short-term or episodic cases. Second-generation topical histamine H1 receptor antagonists are second-line. Antihistamines are more effective than the vasoconstrictors, but can be more expensive. Antihistamines with mast cell stabilizing properties are preferred agent for long-term use. For recurrent or persistent allergic conjunctivitis, mast cell stabilizers can be used as a third-line agent. If symptoms are not adequately controlled, a brief course of low-potency and low-frequency topical steroids may be used. Topical NSAIDs, such as ketorolac, have also been approved for the use of seasonal allergic conjunctivitis, but are generally used as adjunctive agents. At this point, referral to a specialist would be indicated. Oral antihistamines can be used especially if the patient is experiencing additional systemic effects. Some additional measures can also be used as adjunctive measures to improve symptom management, and are as follows: artificial tears to dilute allergens, cool compresses or ice packs, avoidance of allergens, frequent clothes washing, as well as bathing or showering before bed. And
antihistamines can target one or more histamine receptor types. The effects they exhibit vary depending on their targeted histamine receptor type. All histamine receptors are targeted by the ocular antihistamines and have immunomodulatory effects. However, some agents are more selective for one antihistamine receptor over another. Blockade of the H1 histamine receptors reduces swelling, itching, erythema, and pain. Blockage of the H2 receptors reduces erythema and causes vasodilation. Blocking H3 receptors affects nasocongestion, and H4 receptor block reduces itching and swelling. These agents can exhibit efficacy within 20 minutes of application. Drugs that have the combined mechanism of action of intraocular antihistamines and mast cell stabilizers have shown the most efficacy in allergic conjunctivitis and are preferred treatment agents. Mast cell stabilizers inhibit the degranulation of mast cells and prevent histamine release. Ocular mast cell stabilizers have moderate efficacy when compared to ocular antihistamines with or without mast cell stabilization properties. Full efficacy is reached in 5 to 14 days after therapy has been initiated, and therefore these medications are not useful for acute symptoms. These agents may be used for up to 3 months. Drops are instilled in both eyes, and patient compliance may be limited by the frequent dosing of these agents, which must be given up to 4 times a day.
Ocular vasoconstrictors provide temporary relief of ocular redness. Their typical dose is 1 to 2 drops up to 4 times a day as needed. Side effects include rebound congestion, and therefore these agents should not be used for more than 3 days due to this rebound redness. It can also cause pupillary dilation and tingling in the eye. Oxymetazoline has been discontinued from market, and nafazolone is contraindicated in narrow-angle glaucoma. Keratoconjunctivitis, or SICA, is also known as dry eye syndrome, and it is a bilateral disruption of tear film that leads to inflammation. These patients are at increased risk of blinding infections. The cause is either decreased tear production, increased tear evaporation, or an abnormality in the production of mucus or lipids in the tear layer. Risk factors include the elderly, females, smokers, those patients with an inflammatory condition such as allergies, asthma, collagen vascular disease, patients with autoimmune disorders such as RA, lupus, colitis, or Bell's palsy, environmental factors including wind, reduced humidity, cigarette smoke, air conditioning, air travel, prolonged visual efforts, especially towards the end of the day, and medications, including antihistamines, diuretics, anticholinergic, antidepressants, statins, systemic retinoids, and isotretinoin. In addition to environmental controls and treating underlying conditions, the only medical treatment out there for occasional dryness is artificial tears. For more frequent or severe symptoms, patients should be referred to a specialist, and the specialist may prescribe the following agents. Cyclosporin increases aqueous tear formation and decreases ocular irritation by preventing T cells from releasing cytokines that would incite inflammatory responses. The side effects of Restasis includes burning, discharge, itching, and blurred vision, and it's contraindicated in active ocular infections. Lefetograst binds to integrin lymphocyte function-associated antigen 1, LFA1, and blocks the interaction of LFA1 with its cognitive ligand intercellular adhesion molecule 1, or ICAM1. It can cause eye irritation, blurred vision, as well as unusual taste sensation. And the last line agent for patients referred to specialists include punctal plugs. There are a variety of lubricating eye drops and ointments on the market with a multitude of preservatives. The most irritating preservative on market is benzalkonium chloride, or BAK. Here are the products that contain BAK. As you can see, Clear Eye and Visine products often contain BAK. If a patient experiences irritation from one lubricating product, recommend switching to a different brand since most of the brands use the same preservative across their entire product line. You can also recommend the patient to switch to a preservative-free product that comes in single-dose vials. However, these preservative-free options tend to be much more expensive. Something else to keep in mind is that many of the OTC artificial tear products contain other active ingredients. For example, some of the Visine products contain vasoconstrictors to relieve the redness. Since we don't want patients to chronically use ophthalmic vasoconstrictors, we'll want to educate them about multi-ingredient products. Lastly, if a patient complains that their artificial teardrop doesn't last long enough, then you can recommend them to switch to a lipophilic product. The more lipophilic products are thicker and their effect tends to last longer. However, the thicker products may also cause temporary blurry vision. Gels and ointments are great to recommend for our patients to use for overnight relief. The last disease state we'll talk about today is glaucoma. Glaucoma is caused by irreversible damage to the optic nerve and retinal ganglion cells that leads to bilateral loss of visual sensitivity and field of vision. It's usually unnoticed until it has gone too far, and is the second leading cause of blindness in America, being the leading cause of blindness among African Americans. There are several types of glaucoma. Primary open-angle glaucoma, or POAG, is what we will focus on today, and it is 70% of glaucoma cases. Acute close-angle glaucoma is caused by a mechanical blockage of the trabecular meshwork by the iris and is a medical emergency. Any patient that has visual loss must be referred to a specialist. Primary open-angle glaucoma is caused by a decrease in aqueous humor outflow that leads to optic neuropathy. Incidence of POAG increases with elevated intraocular pressure. However, the patient does not have to have increased IOP in order to have glaucoma. Risk factors include age, African American race, family history, and diabetes. Ophthalmic corticosteroids can exacerbate POAG. The agents used in primary open-angle glaucoma treatment either decrease aqueous humor production or increase aqueous humor outflow.
Prostaglandin analogs are the most frequently prescribed initial eye drops for lowering intraocular pressure in patients with glaucoma because they are the most efficacious, well-tolerated, and instilled only once daily. Therefore, they are often considered as the initial medical therapy unless otherwise contraindicated. Other agents include beta blockers, alpha-2 adrenergic agonists, parasympathomimetics, and topical carbonic anhydrase inhibitors.
Prostaglandin analogs increase uvoscleral and/or trabecular outflow and decrease intraocular pressure by 25 to 33%. There are several potential side effects of these agents, including irreversible iris pigmentation that happens in people that have mixed color irises and causes them to turn brown. This discoloration is worse with latanoprost. There are several contraindications as well. There is one DDI, or drug-drug interaction, with thimerosal that can cause precipitation if the agents are given concurrently. Therefore, the agents must be separated by at least 5 minutes. These agents are given at bedtime once daily. If the patient takes these agents more than once daily, it decreases the agent's ability to lower intraocular pressure. Ophthalmic beta blockers cause blockade of beta 1 and beta 2 receptors to cause a decrease in aqueous humor production. This leads to a decrease in intraocular pressure by 20 to 25%. Keep in mind, all of these agents can be absorbed systemically, and therefore they're contraindicated in asthma, COPD, AV block, sinus bradycardia, and overt cardiac failure, especially non-selective agents. Drug-drug interactions include additive beta blockade effects with systemic beta blockers. Generally, all of the beta blockers are given twice daily. Beta-taxolol is the best tolerated because it is most beta-1 receptor specific, and therefore is best for patients with COPD or asthma. Refer to your textbook for an extended product list, as I've only included 2 agents here. Ophthalmic alpha-2 agonists decrease aqueous humor production. Non-selective agents, just meaning alpha agonists, can improve aqueous outflow. These agents decrease intraocular pressure by 20 to 25%. These agents are contraindicated with use of MOAIs, and there's also a drug-drug interaction for an additive decrease in pulse with other bradycardia-causing agents. I've listed the alpha-2 selective agonists here, including its agent by itself and in a combination. Ophthalmic carbonic anhydrase inhibitors decrease aqueous humor production and decrease intraocular pressure by 15 to 20%. They are contraindicated in patients with sulfonamide allergies, and use is not recommended in patients with severe renal impairment. Systemic carbonic anhydrase inhibitors, such as acetazolamide, are very effective in reducing intraocular pressure by 20 to 30%, but cause paresthesia, GI disturbances, CNS effects, and electrolyte disturbances. Therefore, topical agents are preferred over systemic agents. There is a drug-drug interaction if used with high-dose salicylates that can cause acidosis. This is a theoretical interaction and not seen clinically. The ophthalmic carbonic anhydrase inhibitors are listed here as single agents and the one agent that's in a combination. Ophthalmic cholinergic agonists increase trabecular outflow and decrease intraocular pressure by 20 to 25%. One of their potential side effects includes increased miosis that leads to decreased night vision. Their use is limited due to frequent dosing intervals and local side effects. However, there are no reported drug-drug interactions. The most commonly used ophthalmic cholinergic agonist is listed here. The last product I'd like to talk to you about today is Latisse, or bimatoprost. This is the same active ingredient as the drug in Lumigan. It is used to thicken and lengthen eyelashes, which is the side effect of all the prostaglandin analogs. You can see the dosing repeated here. It's important to note that the effect disappears with drug discontinuation, and therefore this medication must be used continuously in order for sustained effects.
In conclusion, proper administration of ophthalmic preparations is key. Bacterial, viral, and allergic conjunctivitis all have different treatment approaches. An appropriate treatment of glaucoma is important to prevent further damage and blindness. If you would like further information on any of the things seen in this presentation, please refer to these references. Thank you for listening, and I hope you learned a little bit about ophthalmic pharmacotherapy.